Anytime.
Well, good afternoon to all. I'm delighted to welcome Vice President Biden to Memorial Sloan Kettering. Mr. Vice President, I want to say on behalf of Memorial Sloan Kettering and the patients and families that we serve that we're honored to host your visit to meet the leadership of New York's cancer providers and innovators. President Obama's proposal for a cancer moonshot really will accelerate the rate of progress against cancer, and it's visionary. And we're thrilled that you agreed to be at mission control. As we all know, cancer research is moving at a remarkable pace, but your commitment and energy is offering new inspiration to the oncology community. This effort comes at a critical inflection point in our understanding of cancer and the ability to use this knowledge to improve cancer prevention, diagnosis, and treatment. The advent of improved DNA sequencing, precision medicine, immuno-oncology have provided new and better tools to address cancer. But the task force you have assembled is already focusing on streamlining cancer research, exploring how to best facilitate combination therapies, and exploring how to reduce the barriers to data sharing and analysis. But we also need to continue to improve access to care, to make the latest diagnostic procedures, particularly DNA testing, more widely available, and to make cancer care more patient-centered. MSK has been privileged to lead the nation's efforts to advance cancer research and improve patient outcomes for over 130 years. And we are pleased to host this roundtable discussion to advance the Moonshots initiatives. Mr. Vice President, I turn the floor over to you.
Well, thank you very much, Doctor. Let me begin by saying what an honor it is to be here. I mean, it is a genuine privilege, and I appreciate you making yourselves available to me, and I see Dr. Baselga out there. We've been hanging out on a lot of these things together. The first two times I mispronounced his name, so if you hear him call me Vice President Biden, it's okay. And Dr. Swaydan as well, and Dr. Huddis. It's good to see you all again, and thank you for the help you've been so far. You know, folks, I say to the press that's here, one of the objectives I have is going to sound strange, and that is how to be able to translate very complicated and, how can I say it, frightening jargon into understandable plain English for, not as opposed to Spanish, as opposed to complicated. To the American people, so they can get a better sense of just the remarkable work you're doing. Because part of the likelihood of this moonshot, and it's probably inappropriately named, but this effort to do in the next 5 years, it would otherwise take 10 to 15 years, depends upon the public's confidence and understanding of what we're talking about. And I know no one knows that better than the doctors assembled around this table who, when you have to explain to a patient you've just diagnosed what this is all about. And the thing that amazes me is and I'm not being solicitous, is the intensity of the devotion each of you have to what you're undertaking. I mean, it is an enormous amount of time, effort, and emotional effort you invest. It takes a really special person, for real. And I say that having unfortunately had some significant experience watching you and your colleagues work. And if I had the time, I'd like to ask each of you what made you decide to devote your lives to treating and curing this series of diseases, over 100 cancers. People think there's cancer and there's one cancer. But it's a life you chose, and it's not an easy one. I just want to say thank you, and I mean that sincerely. I didn't plan on attempting to learn as much as I possibly could about cancer. I'm like every other husband, wife, spouse, brother, sister, father, that when someone close to you encounters a serious dilemma, the instinct is you try to learn as much as you can about it in order to be able to be helpful, no matter what it is. It doesn't have to be a disease, no matter what it is. You try to learn as much as you can. And but like every family that faces cancer, my family and I did everything in our power to learn as much as we could about the particular cancer my my son had, and knowing that we weren't going to have the answer, but trying to find out where to go to get the best answer possible. And we were lucky. We were exposed and had access to the best doctors in the world. The more we talked to the incredible doctors who were treating my beau, the more we realized how much has recently changed. I was amazed to learn that what's happened in the last 5 to 7 years is a bit of an epiphany. Those of you who are in immunology, you were sort of out in the wilderness for the previous 50 years or longer. But what I learned from so many wonderful scientists and doctors making themselves available to me is what I learned is that we're really at an inflection point here. Doctor, you're a great surgeon, and you said you wish we could be better. Well, it's not your hands, doctor. They're as good as they could possibly get in what you could do, but knowing exactly what to do. I watched the surgeons, having done it 100 times, 1,000 times probably, labor over just how much of the glioblastoma could he exercise from the incredibly difficult decisions you have to make on the spot while in there. But what I've learned is that there is a coalescence of disciplines that wasn't even occurring 5 years ago. I just thought it was always this way. But I learned a great deal since, and it's given me reason for hope. And even though it was a difficult time, a year ago, no, almost not quite a year ago, 10 months, 9 months ago, when I decided that when I decided I was not appropriate for me and my family at the time for me to run for president, the president said to me, he'd walk me out to the Rose Garden when I made the announcement. And none of this was planned, but I said, if I have any regret about not running, it was I would have liked to have been the president to preside over the ending cancer as we know it, not ending all cancer, ending cancer as we know it. And it's interesting how something that wasn't planned in a statement just took a life of its own. Before I knew it, the president, without telling me, the devil, was announcing at the State of the Union that I was going to head up a new effort at a federal level, another Moonshot. It could have been called a Manhattan Project. It could have been called anything to emphasize that there was going to be all the firepower we could possibly bring to this issue to try to promote more rapid movement, more rapid change, more rapid progress. And the president made a statement at that time. And that was that, like he did when he asked me to do the Recovery Act, which is over $800 billion in 18 months, he said he literally let the cabinet know. He sent out the essence of an executive order, an internal memorandum, that every single department head and every single element of the government has anything to do with the possibility of dealing with this issue was answerable to me. By that I mean they're always answerable to the president, but he made it clear that there was no need to check with him, and he wanted me to begin to try to organize with a greater sense of urgency what what role the federal government should be playing, how we could eliminate bottlenecks in the process that we have, from everything from approving trials to, just across the board. And I just want you to know, those of you who are working on the bench every day, that I got absolutely there's a sense of enthusiasm as Assistant Secretary, I can tell you, whether it was HHS or Department of Energy. You say, well, what in God's name does the Department of Energy have to do with anything? Well, guess what? We're on the verge of having computers that can do a billion calculations per second. That has phenomenal promise if we can get our act together in terms of aggregating information, which we don't do very well now in this field. And so across the board, every discipline has signed on. And so what I've done, Mr. President, is I've gone out and I called a cabinet meeting, hired a chief of staff, Greg Simon, who is here, who has considerable experience on the management side of this effort. Did the Milliken Foundation, was chief of staff for the vice president in the Gore administration, with Gore, et cetera, and began to organize a way how we at the federal level could do our job better and be more accessible to and more responsive to the needs of the community working on the problem. But I also went around, and which I'm going to end this very shortly, I went around to the great institutions like yours to hear what you had in mind, what you thought, not only what was happening. I've become more educated than I ever thought I would be about the science and medicine behind what you're doing. I'm no expert. My mother used to say, anyone, that a little bit of knowledge is a dangerous thing. Well, I got a little bit more than a little bit of knowledge, but don't ask me to diagnose anything. But the interesting thing is the response internationally and nationally. I've touched a lot of the community. I've heard from thousands of survivors. That's not hyperbole. Thousands of survivors. I've met with over 250 leading oncologists, 6 Nobel laureates. I've met with dozens of philanthropists who've invested, literally combined, billions of dollars in this effort. Your former mayor, I showed up. He asked me to go with him to his alma mater, and he walked in and introduced me, and he laid a check down for $125 million for their new immunotherapy effort down there. So there's a lot of people like Mayor Bloomberg who are devoting enormous portions of their fortune to deal with this. And the interesting thing is that if I have any expertise, and that old joke, an expert's anyone from out of town with a briefcase. Well, I don't have my briefcase with me, but I know a fair amount about foreign policy. I've spent the bulk of my adult life dealing with world leaders. And interesting, no matter where I go around the world since this has been announced. For example, I went to meet with the head of state in the Middle East to discuss ISIS. And before the meeting began, he had his whole team with him there. And he said, Mr. Vice President, I'd like to talk to you about cancer. Can we work out a memorandum of understanding with you? That was an Arab country. Then I went to Israel. Can we work out a memorandum of understanding? Here's what we have done. We had the President had the Nuclear Security Summit. President Abe and President Park of Japan and Korea, respectively, both wanted to, before it began, can we talk about collaborating together? How are we going to do this? So, and the one other point I'd like to make is that this is the only, I've been around a long time, as that old bad joke goes, but it's true. Some of my best friends are Republicans. I was there when we used to all get along. For real. If you notice, whenever there's any problem on the Congress, I'm the guy that gets sent to the Hill. It's because my colleagues up there know I respect them, I respect the institution, and I have real deep friendships. And it's interesting. There's total bipartisan support. As a matter of fact, some of the best leadership coming from the Hill now in terms of funding of this new first year of a new moonshot is being led by Republicans who know what they're talking about in their committees, as well as Democrats, but who are prepared to talking about meeting my request for $1 billion this year, which is, and you couldn't get a commitment to spend a nickel on a lot of other things. The generic point is that there's a lot going on right now, and a willingness to cooperate in ways across the board, across the borders, and as you know, as one of the great top treatment facilities, you care for patients during the most terrifying experience of their life. But our efforts can't just focus on world-class facilities. The thing that I learned that I didn't know before, a lot I didn't know. As you know, whether you're at MD Anderson, where my son was, or at Hutch, or out at the University of California, San Francisco, or the Helen Diller at Family Center in Utah, the Huntsman Institute, or here, more than 75% of cancer patients are treated by community oncologists. They never have an opportunity. They never, and the community oncologists are mostly significantly behind whatever you have here, whatever they have at MD, whatever they have at Huntsman, whatever they have at Hopkins. And so more than 75% are treated by community oncologists, and who are not at all located near great cancer centers. And the thing that intrigued me among many things, Mr. President, what you're doing here is you're focusing on how to get the best treatment plans to patients that are in underserved communities, as well as in those areas where they don't have access. I'm anxious to hear from all of you on what you're seeing on the front lines of patient care and how we're going to go about solving this major challenge. But what I'd like to do is let me tell you what my overarching question is. How do we get information that's available here at Sloan Kettering to a community oncologist in Elmira, New York? How do we get the information that's available at Hopkins to southern Delaware in Sussex County? How do we do these things? I've observed there's a number of impediments. Most major cancer centers don't have an easy way, or in many cases, the motivation to share data, including patients' records, patients' tests, family histories, treatment responses. That has to change. I don't know how. I'm coming to you for help as to how it has to change. Too much published research, as you know, is hidden behind paywalls, leading to unnecessary duplication and failed efforts and wasted time and money. By the way, if I gave you a grant from DARPA and I ask you to work on the space station, whatever you come up with, you have to publish immediately. Publish available to everybody in the world, everyone else doing it. As they say in Southern Delaware, y'all are different. There's no open national network that allows any researcher, physician, or patient access to raw data in a privacy-protected manner. I was talking to one of the docs upstairs. They said, well, it's privacy. I can take care of the privacy problem for you. That's not hard at all. That's not difficult at all. It requires work, but it's not difficult. And so how would this data enable researchers to identify new patterns in patient treatments and get improved diagnostics? We have to support quality analysis to turn raw data into knowledge that helps patients and their caregivers. So there's got to be a way to figure out how we share some of this information, aggregate more of it, in my view. At least that's what the conclusion my team and I have come up with after 9 months of going around the country. And what are other cancer centers doing to extend your reach so the community oncologists and their patients have access to the highest level of clinical care? How are you sharing research results from clinical trials, even de-identified patients data, so progress in oncology research and care can move faster? There's many more questions. I'm going to stop here, but every day you know better than I do, and I'm not suggesting you don't care. You care immensely. Thousands of people are dying. Millions of people are desperately looking for hope. Desperately looking for hope. And So we have an urgency to make a difference, and the Moonshot hopefully will be a vehicle to help generate that sense of urgency and provide some of the pieces that are missing. As my understanding, Doctor, the Sloan Kettering is focusing on patient access, and today we're going to hear from your folks as to how we can improve that. But I'm looking for suggestions. I'm looking for information that help me aggregate some of the proposed changes that we should make either internally, that we have control over by executive order or by legislation, or in terms of playing a role in being a convener to be able to get some more done in the private sector here. And so I appreciate very much your willingness to have me here. And I know, Doc, you MSK is part of the Project Genie and part of data sharing coalitions, but I've met also with I've met with Orion. I've met with Cancer Link. I met with, you're all doing the same thing, and I find it curious. I don't know if that's the only way it can be done. What happens if it was all aggregated at one place? I don't know. So with that, why don't I hush up and Doctor, leave it to you, Mr. President, to call on whoever has any input here. And I'd like to hear from everybody and be more educated as to how we can move things more rapidly.
Well, thank you, Mr. Vice President. I guess I would address one of the issues that you've said in something that's been ongoing for 20 years and is now beginning to outlive its success. We partnered partly in part with our recognition from the National Cancer Institute with a network of cancer centers that have been so designated to form the NCCN guidelines. And that has informed community oncologists over the last 20 years about standards of care. Every 6 months, panels of our physicians with the other leading cancer centers that you've done come together to provide treatment recommendations that can be practiced as a uniform standard across the country. The problem with that is just what you said. We are facing a tsunami of new information being updated every day about that, and a paper record recommendation is just no longer able to suffice. So we have got to figure out a mechanism to get real-time information distributed as fast as possible across the network. And so Memorial Sloan Kettering is participating in that. We participate by collaborating with people like Nat Turner and his company, which is trying to figure out how to aggregate big data and simplify it in such a way that you'll actually be able to find useful information in the time a doctor and his patient have together to focus on critical issues. We've partnered with IBM and their new Watson Computing to form an oncology product that is actually now in beta testing to be used in a community oncologist's office to provide a standardized care and to read those 1,000 journals that publish papers the day before and bring it up to date for that physician. But at the same time, we have to extend the availability because patient care is still a patient and doctor's relationship to develop care. And we've got to figure out a network to deliver that care on a day-to-day basis. Memorial for the greater New York area is involved in expanding our outpatient care network so that no patient has to travel more than 25 minutes to see a care site as they go through cancer care. And they can see the full team, not just one doctor at a time, but patient-centered care, where their surgeon is available, their radiation oncologist, their medical oncologist, genetic counseling for their family is available, social support is all available at each of our outpatient sites. I think that is a model we will pioneer, and we reduce it down to the simplicity of practice. We hope we can get others to engage.
How many of those sites do you have?
So we have 8 of those either in process of working or in the process of being developed as we speak right now. But I think it's equally important to reach out to the extraordinary community. New York is where really 25 million Americans live within 50 miles of where we sit right now. And so it's an opportunity to figure out how to reach every group. And so we have Dr. Carol Brown, who is part of our diversity programs right now. And equally important, we have Dr. Bob Sidlow, who really works on our patient experience, and particularly the issue of patient survivorship, so that as we migrate patients through care, they can go back to their regular doctor with a full standard of expecting care and getting back to wellness, which is what we expect for cancer survivors today. So I think the three of them I've singled out, and I leave it to you to ask any one of them for where they're going with their efforts.
Doc?
Thank you. Well, I would address your question about how can cancer centers or investigators get the information where it's most needed, which there are two groups. One are the oncologists and the other are the patients. And I'd like to tell you one way that a small program that we have here where we're trying to do both. So, my belief is that one way to really reduce the disparities that exist in cancer outcomes is through getting people enrolled in clinical trials, cutting-edge clinical trials of many of the targeted therapies, immunotherapies that are very rapidly being developed. And I think it's equally important that those trials include diverse populations as well. So we have a program where we're partnering with hospitals that predominantly serve poor patients, diverse populations, and bringing Memorial Sloan Kettering investigator-initiated as well as NCI trials, as well as industry-sponsored trials to those patients in their hospital where they're getting cancer care with their community oncologists. Their community oncologists are co-investigators on these trials. They're developing relationships and interactions with our scientists here. And we're having our research staff on the ground there working with the
How do you
patients.
identify it?
How do we identify which sites?
No, who is ready for or would fit into the trial? Because what I hear all around the country is that whether I'm dealing with the pharmaceutical companies or whether I'm dealing with major hospitals, is it's hard to find a sufficient cadre of people for a particular trial. It's a difficult thing to, and there's supposed to be one place you can go and figure out all the trials that are going on in the country, but it's a pretty useless enterprise window. I don't want to say useless. I shouldn't say it that way. It is not particularly. I've not heard many doctors and/or patients exploring it, thinking that it was particularly. So, I'm not sure how you identify the patient that is fit for the trial.
Well, that's one area where we have the advantage of our existing great clinical and research data. So what we do is we sort of do a needs assessment with the community oncologists as to what types of diseases are they seeing, what are their greatest needs. So in many of these communities, things like triple negative breast cancer, which adversely affects women of African descent, or prostate cancer, they have needs for clinical trials in these areas. And then what we do is we go through our extensive database of trials that we have available or that we have available through pharmaceutical companies, and we pick with the oncologist which trials will fit your patient population.
Is there any one place where the trials that you have underway or contemplating can be are published so that somebody in Little Rock, Arkansas, who thinks that this trial at Sloan Kettering is the one that I would like to be part of, to be able to identify and see if they qualify to be part of that trial? I mean, am I making any sense, the question?
Absolutely. I think, one way that happens is on our website, we have, and all the cancer centers and many hospitals do this, you can call and speak to someone about the trials. You can get a listing of the trials, but it is very difficult for a patient to navigate that. Like you said, the issue of plain language. And I think this is an area where I think navigators are very helpful, individuals who can act as an interface between the patient and help them identify trials or...
It's interesting the number of oncologists I've met with who say they have trouble.
Yes.
I mean,
Yes,
it's
that's
not just
correct.
the patient. Is that fair to say? I mean, I want to make it clear. I'm not suggesting that anything's being withheld. I'm just trying to understand what are the vehicles, what are the mechanisms, what are the means by which more of this information can be available, in lack of a better phrase, in readable terms, even for a community oncologist to identify. I have this patient with this particular
Right.
problem, and I would love to get her or him in a trial. I don't know where to go to figure out what trial may be taking place.
So I can just extend Carol's explanation. This is something we all struggle with, and the national average of 3 to 5% of patients on clinical trials doesn't give us a rapid enough advance, and something that the Moonshot Initiative is trying to address. Internally here at Memorial Sloan Kettering, Dr. Baselga has led with his team the development of a tool using informatics to really analyze. So every patient that we see here whose clinical data enters our clinical warehouse actually is identified for the physician that they're eligible for certain trials. And so automatically the caring physician, after seeing the patient, receives information that this patient, if the patient and the physician so choose, can actually be eligible for this clinical trial. That allows us to have about 31% of our patients right now on clinical trials.
Gotcha.
That's really about right, because about 2/3 of patients, the standard of care is actually delivering on its promise right now. That has been the advance over the last 40 years. The bigger issue is how you advise somebody who's not in our care network, and therefore we don't have all the records, where we can use analytics that Nat and others are developing to actually help make that decision for them and make sure that eligibility based on the criteria of the trial are eligible. That requires, and we do provide all our clinical trials to nci.gov, which is a warehouse, but that provides just the basic information of being eligible. So one of the real problems we have is someone in Little Rock actually sees that there's a trial available in Memorial, and sometimes will get in a plane and fly here before we've had a chance to talk to them or their care provider, only to discover we can't enter them into the trial because they meet certain eligibility criteria that just won't make it a valid trial if we put them in, and that becomes a very difficult situation for everyone. So we've got to figure out, as Carol said, how we get someone to facilitate. We like the use of navigator systems, trained professionals who can cut through that difficulty, as you said, to understand all the norm and can actually get down to the essential nature of whether or not that patient will be eligible as an interface for that. But ultimately, big analytics will help us with that.
I'd like to ask you as a favor, if as a follow-up to this, there are some folks with whom I've met, and you know them all, who are genuinely trying to find this answer. If you'd be willing maybe to meet with some of our folks, I don't mean today, but in the next month or so, to actually brainstorm I'm getting I don't want to take the time here, a number of suggestions as to how to do that. And you have forgotten more about this than I'm going to learn. And I'd like to get some of you together to say, okay, this is an avenue we might try, and to be able to do that. Because the thing I've found is everyone in your position agrees that something has to be done. So that would be helpful if you'd be prepared to.
Well, I'm willing to commit Dr. Charles Sawyers in terms of molecular data and his leadership in Genie to that, Dr. Baselga for the clinical trial organization, and the team under him, Dr. Pete Stetson and Paul Sabatini, who really are the experts in helping us identify how it is. And we'd be very interested in helping participate in the actual effort on that.
I know I'm taking a lot of your time. I'm sorry I have so many questions, but
that's absolutely fine.
I don't know where to go from here. Who's next? And anybody has something to add, I could. And by the way, if it's a nurse, I'll listen.
Okay.
Go, Sue.
Thank you. So I'm just so happy to be here to share a nursing's perspective of care, of oncology care. We really are on the front lines, and we see patients go through the toughest times. And I heard you mention that it's frightening. It is frightening. The drugs that we give patients are frightening. The treatments that we give them are scary. They can have potentially serious reactions. And the nurses are there through every step of the way, and we have such a bond with our patients. I just want to share with you a little story about a patient that I had recently, and just some of the hardships that they go through, and how nursing is a critical role in this whole project that we're working on and we're all trying to do here. I had a patient recently that was preparing for bone marrow transplant, and he was getting very expensive injections that he left at home. So that's thousands of dollars right there that were wasted. He came in, he was obviously stressed out, he was very upset, he didn't know what he was doing there. He said, why am I doing a bone marrow transplant? I can't handle this, I can't go through with it. He just had his head in his hands. He was obviously in distress. So I spoke to him, and it turned out that he's living on a fixed income. His family is supporting him financially. He lives 2 hours away, like I mentioned, and it's just so hard for him. He was living in a hotel for the process of his bone marrow transplant. He wanted to give up. He said that he just wanted to go home and live for a year with pain medicine and then die, instead of being a burden to his family and to his friends. So, from there, what we did was I called the physician, I get social work on board, I got the office practice nurse on board, and he ended up going through with the support of the collaboration of the team, and really ended up being successful and living 5 more years with good quality life. And who knows what's to come for him after that. But the bonds that we see in the front lines and the struggles that we see is just really evident. And I'm so happy that we're thinking about these things and taking the initiative to move forward faster and to really accomplish something together collaboratively.
Well, by the way, that was my experience. I watched the treatment in the last days with my son, who had stage 4 glioblastoma, and he had gone through a trial with anti-PD-1 and a adenovirus injected in his brain, and I watched the nurses 24/7, and I watched the meticulous records they kept. And they sat there, 24 hours a day. And the meticulous records they kept on the reaction he had to every single thing that happened. And I watched the oncologists when they come in, or when the folks would come in from the neurosurgical department to get him down for another CAT scan and see what was happening, et cetera. And I watched the nurses would go, "Doc, I don't think this is a good time." The doc would say, "Okay, not a good time." Listening to the nurses because they were keeping such meticulous care. And I am told, and I believe it wasn't just my son in this facility that was getting that kind of treatment. But one of the things I'm hearing from these meetings is there's a concern of the number of practicing oncologists and the number of providers entering oncology specialties is insufficient to meet the demands. Should we be doing something? What targeted intervention is there, or should there be, at training or academic level to encourage more healthcare providers to go into oncology on the nursing side, particularly? Is there, or just because it's such a great institution, you may not have everyone who would want to be here who is in this field. But is that a problem, or is it as a
Cindy, you might want to address this.
So I'm speaking from the standpoint of mid-level as well. I'm a physician assistant, and I think a lot of times people that are nurses or physician assistants or nurse practitioners that are in training, they're a little afraid because of the oncology and knowing that it's a long process for the patients and also can be taxing. But I think the reward that you get seeing patients that survive 5 years later, if they could be able to rotate through, given the opportunity and seeing the work, the research that's coming about for oncology, that can help motivate and allow people to be more involved.
Yeah, and the story too that I told you about, the patient needed to hear that. I did express to him that if you get this treatment, you may have a better quality of life than you are right now for about 5 more years, and then you don't know what's going to happen next. you don't know if there's going to be another clinical trial that these wonderful immunologists are thinking of. You never know what's going to come out of the woodworks. And, we give them the hope to hang on, to stay strong, that, something better might be coming your way, and we might do this.
But you're right, Mr. Vice President. I think we do need to excite new talent into the field at all levels. And one of the big issues is how we preserve our training mission here at Memorial Sloan Kettering. Every year we train 1,700 new nurses and physicians who get exposed to what can be accomplished, what Sue was just talking about, that it's not a hopeless situation, that we have new and evolving treatments, and that they get part and get excited, as Cindy said, about that. One of the biggest groups that Sue identified that we're concerned about right now are young adults, adolescents, and older children who get cancer, because they have special support needs, and they often are living for the first time out of college on their own. They don't have the support networks immediately available as a family as they've moved to start their own careers. And that's a critical area. We have a lot of exciting stuff in what the President's announced around precision medicine, what Jill and her colleagues and you helped spear in terms of immuno-oncology. But the special needs of pediatric and adolescent oncology, particularly around both the care and the new insights we have, is something I hope Mark can speak to, because he's been a leader in that area.
I appreciate it. And two comments first, if I may. And you don't need compliments from me, but compliments to you and the administration for doing what you're doing. I think it's a phenomenal feat. If you need confirmation that the moonshot was the correct phraseology, I would support that. I think the greatest American hero in my lifetime, Neil Armstrong, lost his daughter to a malignant brainstem tumor, the disease I've committed my life to. And interestingly, if one were to ask him, 7 years before he walked on the moon, should we apply this type of resource to save my daughter's life or walking on the moon, I think it's self-explanatory what he might have commented on. So I think the phraseology is perfect in our country. And the comment that I also want to make with regard to what we were discussing before as far as exposure and access, what always amazes me from the standpoint of individuals who seek and look for an applicable clinical trial or conduit for treatment, huge barriers, there's no question. You obviously have a wherewithal and an ability to do that research when your son was diagnosed. For the individual who doesn't know the difference between a clinical trial and a cough medicine, it becomes unbelievably problematic. For the family who doesn't know the difference between Hospital for Special Surgery, Memorial Sloan Kettering, it's a huge barrier. We've got an amazing conduit through social media to accomplish just that goal. So if someone searches glioblastoma on the internet, maybe the first thing that comes up isn't an advertisement, but maybe it is a peer-reviewed conduit for applicable clinical trials, not just in the United States, but worldwide. Right. And these should be somehow owned by peer review that looks at these and documents whether or not they're legitimate. Because there's a lot of abilities to do wrong as well. There's no question. As far as the special needs for pediatrics, my heart will always be, treating the child, and it's not so much treating the child, but as Dr. Thompson mentioned, it's the special needs of the child. It's the sibling. It's the parent. And the reverberations of this and losing a child to cancer, I don't have to tell you, are huge, to say the least, and that's an understatement. So the special needs are something that I think delve well beyond cancer therapy, and everybody sitting in this room and at this table are individuals who are expertise in every one of those elements. But having programs set up for siblings, having programs set up for reintegration into school are so critical to that individual feeling as if they're doing their life's expectations. So I could go on and on about the special needs of children, but I'm not one, and I'll just say in the same breath, to critique funding sources or the FDA for not applying the same emphasis on pediatrics. It's a subpopulation of our community, a very important population, no question. But it's a minority relative to what we see in the adult population with cancer, so it's understandable.
What folks who specialize in it are telling me is that it may be, there's rare cancers, but it also may be open the door to much broader application for the adult population as a whole. one of the things that I was down at a meeting like this with Duke and University of North Carolina, and one of the things was raised was some of the docs were saying that pediatric oncology has special needs, special requirements beyond the actual surgery, beyond the actual treatment. But they said the group that seems to be most adrift are children between the ages of 16 and 23 or 24, because bringing in the clowns or the dogs or the the movie star or whatever doesn't to keep the sense of optimism alive. It's just a heck of a lot harder. And they went through examples of how much more difficult that group of young adults, I mean the 16 to 18 or 20-year-old, what do you do for beyond the treatment, but the holistic treatment of that patient in terms of preparing them for and giving support. And is that your experience, or I mean, is that a discrete group of patients that require that we haven't quite figured out what is the support system that we set up?
And of course, I don't have an answer, but you've done your homework. That's an important age category. You know, for the 4-year-old, the world isn't this large, kind of pre-formatted idea about what's going to happen in their life. For the college graduate or the high school graduate, there's a whole bunch of ideas and dreams and things that they anticipate are going to happen in their life. So truly a unique set of circumstances that affects that individual in that age group versus the infant or the older adult. No question about it.
Well, if my mother were here, Doc, she'd look at you and say, "Son, you're doing God's work." No, you really, it's you guys and women, you're absolutely amazing. It's just breathtaking. But when I said early on about, I admire your courage, because the very reason why you may not have as many nurses picking oncology as some other field. I remember I had a couple cranial aneurysms and a major embolism, and I remember asking my neurosurgeon, who was a great surgeon, well-known guy, I won't embarrass him and mention him, but I spent a couple months in ICU, and after it was over, and I was finally released after the second craniotomy, I said, "What can I do?" He said, "Joe, what you can do is you can go back to the ICU nurses every once in a while and bring them some food and dinner, talk to them." He said, because there's virtually there's no remuneration they get. Somebody leaves the neurosurgical ICU unit, they either leave on a platter, on a stretcher, or they walk out and they never want to come back. So they never get to see the guy who 5 years later is still around. So I admire the heck out of you guys. But anyway, thank you, Doctor. Who's next?
Well, I think one of the things that we really hope, and you're taking the leadership in the story you just told us, is that it will, in the adult community, the issue is a number of people avoid screening, or they think there's no hope for cancer, that if they get it, they don't want to know. And increasingly, we're in this decade going to have 16 million cancer survivors in America. People are back doing everything they hope to do for decades into the future. So one of the two areas that we're spared that are represented here, I don't know who should speak first. Rob Sidlow is taken ownership of our survivorship program. We have over 1 million survivors in the New York area that we are supporting, and they need to get out the word. It needs to be understood that the earlier you catch it, the better you can get things to prevent it, the more likely you are to lead a full and healthy life afterwards. There's real hope if you have a diagnosis of cancer. And Mary, on the other hand, provides an absolutely essential screening activity. So I leave it to you. Sure. Which end of the spectrum you want to ask them about?
You're on, Rob. All right, thank you. So I come to this conversation as a probably the only non-oncologist in the room as a general internist. And one of the challenges we really have is how to disseminate the survivorship, the knowledge of cancer survivorship to the community practitioners who are out there, the ground troops, because there are only so many Sloan Ketterings, there are only so many Dukes, and most of the survivorship care is not delivered here, nor should it be. So the challenge is how do we educate and normalize the care of long-term cancer survivors out in the community. And one of the efforts we're really trying to do is to break out of our intellectual and academic silo and reach out to other medical groups that are practicing within a 50-mile radius of our center, and to meet with clinicians out there and to educate nurses and care teams about how to actually do survivorship care well, and make those transitions of care seamless.
Well, this is one of the areas that in the report that I'm expected to deliver. I'll be an interim report in the fall. This is one of the areas that we need help on, because given how quickly aggressive treatment, for example, chemotherapy follows cancer diagnosis. When's the optimal time to encourage patients to be the drivers of their own care and their own treatment, and how do you do that? And there are things that, again, Doctor, it would be helpful if we could follow up with you on the telephone with our folks and get some ideas about how you are approaching it, and how you think we should begin to set some national standard, not legislative standard, but a standard as to how to proceed that way. We'd really be interested in your thoughts. It would be helpful.
I'd be honored.
Thank you. Mary?
So I'm the director of Project Renewal's Scan Van program. And what we do is we provide mammography and clinical breast exams on board a 40-foot van. We travel all over the city. We partner with about 250 different community-based organizations throughout the city to target specifically underserved, uninsured, or poorly insured women that are not coming in for screening for whatever reason. Here we are in New York, probably the mecca of the world when it comes for cancer care. Kings and queens come here for care. You can literally walk through almost any institution's door and get care. The question is, why aren't patients coming in for care? And there are lots of reasons, lots of barriers out there, much education still to do. But if you ask a woman today, does she know what a mammogram is and what advantages a mammogram can bring her? She can probably recite them to you in just about any language here in New York. The problem is access. And can we meet her so that we really don't disturb her day? In my world, I'm dealing with women, and we're just about the last person on our list. If our kid coughs, he's going to the doctor. If my dog has a hairball in his head, he's going to the vet. My husband needs something, my mother needs something, my father or in-law needs something, well, I'll make it happen. But for me, I'm a working woman, I've got things to do, and I'm taking care of everybody else. But when my van is tripping me on the way to work, I'm tempted to get this important exam done. We're also providing colorectal care by providing those women that haven't had a colonoscopy in the last 5 years with a simple fit kit, explaining how to do the test. But the most important part of our program, in my view, is the navigation aspect. It's not enough to screen, but it's most important to navigate those with abnormalities to care. I consider myself a big cull machine. I am out there separating the well, which is about 85% of the population, from the may not be well. And my job is to take that may not be well patient and get her here. or get her somewhere in New York where she can be seen for diagnostic workup. And that's what we're good at. I wish I could tell you we don't find breast cancer, but we do. We find it in alarming numbers. But the vast majority of women that we see are asymptomatic, and they're early breast cancers that we're uncovering. And these women have a bright future. And with the help of the navigation staff, you can almost ensure that. My message is, in public health, we have few dollars to spend. What we need to do is to take that dollar and stretch it over as many patients as we possibly can. You need to deliver these screenings at a very low cost, in a very efficient setting, so that you can separate the well from the may not be well. It's very expensive to bring patients into institutions and just turn the lights on. For me, I cost a lot less. We need thousands of low-cost centers feeding these very high-end centers with patients and providing the navigation that those patients need to keep them in the continuance of care.
I couldn't agree with you more. One of the things I'm proudest of is in my home state of significantly increasing the number of mobile vans that are flying through the east side. And we have the 8th largest African American population in America, and enormously underserved. Now it's beginning to change because there's not a van, there are multiple vans in a small, our whole state is smaller than any one borough here in terms of population. And so I think you're absolutely right. And also, one of the things that we're doing in healthcare overall is that's why we've funded so much emphasis on community healthcare centers, community centers for providing healthcare, and being able to navigate for them if they have to go beyond that. So, thank you for what you're doing. We initially had trouble getting a consensus that this was a funding initiative that made a lot of sense, but it's beginning to change. And so, with the grace of God, the goodwill of the neighbors, will keep moving. Thank you for what you're doing.
And then I think the last issue that we just wanted to address in terms of something very important to us are our advances that are going on in precision oncology as well as immuno-oncology. These are unfortunately get into the news not only for their tremendous success, but also because of their cost. And so it's equally important that we begin to identify who best to give those treatments to. And so Jill O'Donnell Tormé and her group, Cancer Research Institute, has pioneered new approaches to understanding immuno-oncology and how we pick out the patients who should receive that as a potentially curative therapy. And Nat Turner and his colleagues are really on the informatics front, providing analytics that will ultimately, we hope, help us identify who best benefits for things like precision medicine. And so Flatiron's efforts, I want to at least give them each a chance to talk about those things.
Well, I'm obviously coming from a different side than what you've heard already. The Cancer Research Institute is an organization that's been around since 1953 and has always supported research on the immune system and how it could be used to treat, control, and eventually cure
Finally paying
cancer.
attention, aren't you?
Finally. So we finally got there, and I think that tells you just something about research. And I think if we want to change cancer as we know it, I think the root of it always comes back to supporting research. And it's research at the laboratory level, at the translational level, and at clinical trials. And so I think one of the big things have to be do is that we need consistent and sustainable sources of research. The federal government and NCI supports the majority of research in this country at academic centers, and I think we want to see a steady flow of those monies flow, and that it can't be an up and down thing, because research, that's the one other thing too, as I always say, research isn't linear. You can't put a dollar price on it. I can't tell you, give us $1 billion, we're going to cure all cancers. I think you have to support good people, bright people, and get them to work together and to connect the dots. And this is where discoveries come from. And I think it's very important to support that. And I think we're a not-for-profit that obviously is a small supporter as compared to the federal government, but I think there's also a role for not-for-profits in this space. And how do we bring collaboration together? I think we have a very interesting model in terms of our clinical accelerator of being a way way to de-risk at early stage clinical trials of bringing academia and pharmaceutical companies together to test new combinations of immunotherapy and do the deep correlative research that needs to be done, the mechanistic understandings, because we know combinations are where the future are, but there's an infinite number of combinations that can be tested in cancers, and clinical trials are very expensive, and we don't want them to fail at phase 3. So I think we need to relook at how we do clinical trials, and at the early stage, really deepen and not just do yes or no answers, is there a clinical response, but we have to get these really precious patient samples. In the immunotherapy field, we now have a large percentage of patients that are responding durably to immunotherapies, but there's still a large percentage of patients that aren't responding. And for the first time, we can now ask questions that we couldn't ask before. Why are these responders responding and the non-responders not responding? And that requires getting biopsies and patient samples and understanding what's happening in the tumor microenvironment. And I think we have to understand in a more broad way is a way that a lot of there's probably now hundreds of combination immunotherapy trials being sponsored by pharmaceutical companies in the United States right now.
Only recently.
Yeah, only recently. But we need to be able to find a way that they share those patient samples in some way, that they get shared among academic researchers, that we can ask questions and use these in the ways so that we can really learn what do you really bring next as a combination into the clinic, and what can then go on to become phase 3 and standard of care. And that's a really important goal, and I think that's where the future holds. And it's going to come down to bioinformatics, too, and sharing data. So I think let Nat take it on from there, but I think that's where the future is.
Before we go to Nat, I've had a chance to spend some time with Nat in my home, and with a guy who some of you know, Eric Lander. He's a bright young man. It's like, anyway. One of the things that the aggregation of information that could help determine why one therapy worked on one patient and another patient who had a similar circumstance, it did not work. We now have tools that could accommodate that much more rapidly, and the more data that can be aggregated in one spot, and the more thorough data, the faster route. It would take 1,000 oncologists the time to do it. If there were 2-3 million biopsies that were readable, 2-3 million treatment regimes and how we response and actions, the genome. I mean, we can learn a whole hell of a lot awful quickly. One of the things that Nat and I and Eric Lander talked a lot about is that when we wrote the Affordable Care Act, before that was written, we had a thing called the Recovery Act, which had over $800 billion that we spent in 18 months. I might note, for the record, less than 2% waste or fraud or abuse. When we wrote that during the interregnum period between the time we were elected and the time we were sworn in, the president and I sat alone out in that 67th floor, I think it was, the Chicago office building, putting together a new administration. And we had the leading economists in the country, from the Larry Summerses to former heads of the Fed, talking about the need for massive stimulus. But we decided to try to use that also to change the way we govern and to do it more effectively. So one of the things we did, everybody talked about electronic record keeping for docs and it being able to be easily transferred, and we came up with $35 billion in that legislation before the Affordable Care Act to accommodate doctors being able to transition to electronic records. We thought we knew what we were doing, but what we didn't realize is that we essentially put up 5 different firewalls. All $35 billion was spent, but the ability to communicate, aggregate that data, with, unlike the human genome, no agreed to vocabulary, You know, you got a broken femur, I got a broken leg. Well, the computer doesn't pick it up. So the big debate has been, what do we do? Do we get docs and medical schools to start to do with, which is very difficult, common definitions of common language, so we can be able to transfer those records and know what's in the records? Or do we go to Flatiron? And what Eric Landler was talking about, he said, by the time we get the system right, it's going to be too late. And so what we got to do is, and I'm going to embarrass you now, but say to go to brilliant young minds like Nat and figure out how we can go in and using the existing technology we have to be able to interpret from the data that exists what's there. And so have you solved the problem yet, Nat?
I wish. Yeah, I'm going to show this recording to my mom. She'll finally understand what we're doing, so this is great. So, yeah, and first of all, I've told this before, but thank you for everything you're doing in the fight against cancer. And Jill, you're speaking our language. I'm so happy to have met you today. There's a lot going on that's really exciting for cancer care right now. And it all starts, and we're biased with data, and we spoke about this. And, we actually work with that community practice in Little Rock. And they have patients receiving those immuno drugs, as does probably every community practice in the U.S. There's thousands of them, and we work with hundreds of them. And there are other organizations like ASCO that are working on similar efforts. And our big problem and yours is science just isn't moving fast enough. There's all this data out there, and we've had to raise hundreds of millions of dollars to liberate it, because we have teams, almost 300 people, engineers from places like Google, who still can't figure out how to make sense of all this data. But what the Recovery Act did is it got all this stuff in electronic format, which was a huge, huge step forward. So we are making strides as an industry where we have armies of people and machines that are learning what these PDFs and documents and scanned images say. When it says Mrs. Smith has this genetic mutation, she responded to this therapy or didn't respond to this therapy, here are the side effects that occurred. That's actually happening, and it's super exciting. So if I give you a quick example, so we announced yesterday we partnered with the FDA to look at this information en masse for immunotherapies, because we too want to know, why are there only 20% of patients responding? No one institution, including the one we're sitting in today, has enough patient data to figure that out. So an aggregated data set is what you need. And so we just looked through our database and found tens of thousands of patients that received those drugs. And we have linked data from genomics and other sorts of tests that we think might lend some sort of signal as to why are those 20% of people responding, and can we really target them? So I think the good news is that the industries, in large parts, a lot of your efforts are very open to data sharing. I think we're actually past that. In years past, institutions treat their data as intellectual property, even though the patients own it. We're largely past that. What we're now into is we're in the trenches on how to make sense of all this data, get enough of it, get community oncologists, access to the same clinical trials that a place like Sloan Kettering has. I know community practices in, for example, South Carolina that shut down their clinical trial operation because it's too expensive. They can't afford it. They lose money on trials. And not every patient can get on a flight to New York or Hopkins in Baltimore or Houston for MD Anderson. But there are ways we can do that through technology, where on every doc, when I go to a meeting, I see their mobile phone. It's a smartphone. What if right before they walk in the patient room, it says, hey, there's 3 trials you should think about? We have to get to that point of simplicity. And I'm really excited what's happening, but I think immunotherapy is probably where we're going to see the first breakthrough of this information being used to really figure things out.
Well, Mr. Vice President, I really want to thank you for coming here. It's just inspiring to see your leadership on the Cancer Moonshot Initiative. I think we can make one promise to you back, and as you queried us, we're fully in. Anything you need in terms of our help and support and our expertise, we would love to provide to you and your team as you continue this, making much further awareness of what's possible in cancer and accelerate our ability to deliver to patients and their families. So thank you for being here.
Thank you, Doctor. And it's really an honor to be here. And we're working on trying to essentially more or less be a convener and accommodate some of the things that have to happen. But we are looking for, and I am hopeful, working with my leading Republican and Democratic friends in the Senate and the House, having a guaranteed multi-year funding stream. We're also working to at NCI and NIH to figure out a way to better accommodate with more efficacy the clinical trials and funding streams for research, so we're not being redundant. Redundancy is necessary. I'm not suggesting there's one route, but there are, and in order to get a grant of any consequence in this area, you got to have basically a sponsor you've been working with for 15 years, and you may have a brilliant idea, but if you're 31 years old, you're not in the deal, man. There's very few chances we take, and we got to figure out how to break out. I spoke to 6,000 oncologists down in New Orleans. I'm heading out to Chicago, and 6,000 or 8,000 more I'm going to be speaking to. And when I started talking about how grants are awarded for research grants, and I started pointing out some of the problems, spontaneously, 1,000 researchers are standing up cheering. No, I'm not.
That's true.
Some of you were there. Am I joking? I mean, it was, and these are things that it was like, the dirty little secret no one would say it out loud. We wouldn't say it out loud, but we're now, I'm the bad guy, I'm saying it out loud, and people are going, oh, God, I didn't know you knew that, But so, I mean, there's a whole lot. We have to spend a lot more money, and you don't know whether the first dollar or the last dollar will have any impact. And there has to be a certitude of funding that is people can look to. But also we got to change the way we do it. And we have to incentivize. There's more and more just in the last year since we talked, Doc. There's a lot more sharing going on here. A lot more information is being disseminated, and cross-pollination is occurring than it was literally a year ago. And it's really, it's useful. And you have the FDA stepping up and to another level. They, using more than one drug at one time. Well, that was like an epiphany, that occurred. And drug companies have been, in some cases, anxious, some cases embarrassed into saying they got to be part of the problem. Now, granted, there's some legitimate concerns they have about safety and their exposure, but so I don't want to be Pollyannish about this, but I think there is an emerging, slightly different mindset as to how to proceed. I'll conclude with this. One of the most interesting conversations, Doc, I had. I met with a group, totally different reasons, the President's PCAS board, and we were talking about some funding that was related to outer space and mapping the star, and they talked about how they qualify for the funding and the rest, and they started talking about, well, so-and-so just did that, and they published their paper. I was able to offer that, get this. And I started talking to them, and it was like, wait a minute. You mean you guys, you actually do the research that taxpayers pay for, and you share it instantly with everybody else? And I said, it looked at me like, yeah, what's the issue? I said, well, come and talk to the docs with me, will you? Come and talk to the hospitals with me. I'm serious. Now, I realize there's some legitimate reasons why that doesn't happen. And I understand there are proprietary. I really do get it. So I need you guys to help me. What incentives what change in the incentive spectrum do we have to look at to get this move in this area of science like we do in other areas of science? As this one leading astronomer said, well, they don't play well in the sandbox. We do. I think that's a little exaggerated, but you know, there's and the drug companies are going through the same sort of epiphany in terms of what is able to be done. But what you're doing is miraculous work. It really is. To anybody listening to hear this, you'd think, well, you know, Biden came up and we all talked, and God, woe is me, we're not making any progress. There's been enormous progress made. But the question here is, can we exponentially move the needle here? And by the combination of funding, this change in the nature of how we do research grants, the means by which we aggregate data, the capacity to analyze that aggregated data, which is enormous. You know, when I say places that right now we have the capacity to do 1 million billion calculations per second, people look at you like you're nuts, but think about how far we've come in the last 10 years. And the reason, you know who the most enthusiastic person in the administration is about this whole effort? A brilliant nuclear scientist from MIT named Ernie Moniz. Because he looks at it and goes, whoa, we're on the verge in our labs of 1 billion calculations per second. And let me tell you what the application can be, Joe, if you do whatever. And the other thing is that you all know, and the public doesn't, nor did I, how many disparate disciplines need to be engaged in dealing with the end objective here of fundamentally altering the way in which we're able to treat cancer. You know, some of the people we met in Davos with were biological engineers. They had no background, none, zero, in medicine or cancer. You know, I mean, but so there's a lot of hope. I am optimistic, and it's been an honor to be able to be here. This is one of the great institutions in the world, and I want to thank you for letting me participate. But I warn you, we don't go away easily. We'll be calling you and asking for help. Okay? Thank you very, very much. Keep on driving, Mayor. Keep on driving.